It's our delight to bring you together for this convening. Our goal here today is not to present you with the typical talking head who stands in front of the room and lectures at you while you stay in a passive position. Our goal today is to have active, lively, provocative discussions, both with our speaker and among ourselves. So we will not allow you to be silent and simply sit and take notes. We really want to engage in conversation. As Karen said, we're at a very critical turning point where we're now going to try to build an affordable healthcare system. We also know that ours is the most expensive healthcare system in the globe. And yet, in terms of medical outcomes, we rank last among the industrialized nations.
I'm really excited to be here, and let me tell you why. The reason I became an economist way back, I'm thinking to when I was an undergraduate, was I was drawn to the idea that what defines our performance as a society is how we take care of the people who live in the shadows of life, who live in the evening of life, the people who are sick, the people who are poor, the people who are elderly. That's really how we deal with those people, and what we do for them is really what defines us as a society. But I realized at the same time that Washington and the State House in Boston speak a very different language. They speak the language of economics, and the language of economics does not deny the fact that there are people who live in the shadows and people who live in the evening of life. But the language of economics is all about measuring what works and what doesn't, and what the alternative investments are. So every time someone comes along and says, gee, I'd like to do this for this particular group, it is the job of the economist to say, but wait a second, there's this other group that yesterday you were arguing was the most underprivileged group, so why don't we divert resources to them? So there's trade-offs in life, and I felt that becoming an economist was a particularly good way to connect people who are advocates, to connect people who are providers with people who make policy. And I'm not a policymaker, I'm just the guy who sort of shuttles ideas back and forth between the two groups. We agree as a society that one of the best things that we can do for people is to make them as healthy as possible. Economists and philosophers agree on this. It's a question of rights, it's a question of capabilities. When people are healthy, that's really the only way that they realize their full capabilities. But a lot of keeping people healthy requires us to spend more. Right? It's true that there's a lot of fraud, waste, and abuse in American healthcare, and if I could wave a magic wand, I would like to get rid of that fraud, waste, and abuse. But even if we did that, new medical technologies will be discovered and they will be expensive. And if we want to keep people healthy, we will have to give them access to those medical technologies. Even if we don't want to give them access to those medical technologies, even if we just want to invest in public health is expensive. It's not for free.
You know, I've been around healthcare for 25 years, and when before my exposure to Culture Insight, I viewed disparities in kind of a narrow way, and they've really helped me broaden my understanding and my organization's understanding of what disparities are.
We're doing something very different as a country. What we're doing is saying we want to be healthy and wealthy, so we're going to ignore the trade-off. And so if you ignore the trade-off, you need to come up with the money from somewhere else. And what we're essentially doing as a country is we're raiding education. So we're taking money out of education to finance healthcare so that we don't have to increase taxes on ourselves because we want to be healthy and wealthy. And it's a particularly dangerous form of redistribution because the people we're taking money away from are people who are young, outside the democratic process, and often unborn. This is something that I'm always drawn to again and again. This is Peter Fisher, Undersecretary of the United States Treasury, testifying to the US Congress in November of 2002. And he says, think of the United States government as a gigantic insurance company with the sideline business in national defense. This is a Bush administration appointee, so that's why there's a sort of very simplified analogy. But it's a good, powerful analogy, a very powerful, accurate analogy. This particular insurance company has made promises to its policyholders that have a current value $20 trillion in excess of the revenues that it expects to receive. It is an accident waiting to happen. So what he's telling Congress in November of 2002, 10 years ago, is, gee, if you look at the balance sheet of the United States, if you look at what we expect to pay out in terms of Medicare and Medicaid relative to what tax revenues look like, by the year 2050, we have to come up with $20 trillion more than what we expect to take in. The human mind is not very good at understanding the difference between 40 million, 40 billion, and 40 trillion. That is something that economists are good at doing. So I'm going to put those numbers for you into perspective. But the one thing I want to point out to you is that if you look at what is the source of this $40 trillion surplus, I want to kind of point out that almost all of it comes from the growth of the health programs and not Social Security and other forms of spending. So if you look in the top figure, what you see is that the share of GDP that will be absorbed by the Medicare program and the Medicaid program is galloping up over time. If you look at Social Security grows as more people age, but Social Security is a program that in some sense is not a program, I mean, maybe it's a program that we should reform, but it's really not going to be the principal cause of the accident that's about to hit us. Nor is it other forms of spending like defense or the National Public Radio budget. All those things are minuscule compared to the first thing, which is spending on health. That's really the thing.
Really curious to see how economics plays into the way equity is distributed in health in general. And I think that the remarks that were made around containing cost and increasing effectiveness can allow resources to be made available to address the things that actually determine health, such as the social determinants of health.
Massachusetts, as you know, led the country in insuring the uninsured in 2006. So if you look at the state budget, between 2001 and 2011, state spending on healthcare grew by $5 billion. This was a 60% increase in healthcare spending. This was incredibly valuable. We know that the Medicaid program, we know from the Oregon Health Insurance Experiment, which is now about a year old, the Medicaid program is incredibly valuable. Health insurance is valuable, but it is also very, very expensive. And in the case of Massachusetts, it increased government spending on healthcare by 60%. How did we pay for it? We're just a microcosm of the United States. Did we increase taxes? Did we lower benefits? The answer is no. We did something that I refer to as ignoring that trade-off between being healthy, being wealthy, and wise. We took most of the money out of every other area of work that the government does. So if you look at government spending on public health, it fell by 40%. If you look at government spending on mental health, it fell by 30%. If you look at government spending on education, it fell by 15%. On human services by 13%, on local aid by 50%, and on public safety by 11%. Now this boggles the mind for an economist because, as I said at the start of the talk, economists believe that people should be healthy. But the single best way to keep people healthy is not to spend on healthcare. It's actually to invest in education, to invest in mental health, to invest in public health, and to invest in public safety. So if the goal is to keep people healthy, it really boggles the mind as to why we would do less of the thing that really matters and do more of the thing that's valuable. I'm not saying it's not valuable, but it is less valuable than these things that we're rating. And so what I want to think about, what I want to get you to think about is three things. The first is the insurance itself, and this is a provocative thing to say. The act of insuring people gets them to consume more healthcare. And we as advocates have done a terrible job, and we put the president in a terrible position by telling the president, if you insure people, they will be healthy, and because they will be healthy, they will spend less money. That's actually not true. The second reason that we got into this mess is we decided to pay for healthcare using fee-for-service medicine. Now, fee-for-service medicine, everybody beats up on fee-for-service medicine, and I'm going to beat up on it too, but I'm going to give you a different reason for beating up on it. The reason that we often beat up for fee-for-service medicine, whether you're talking to President Obama or you're talking to Representative Ryan, they both hate fee-for-service medicine. And they both hate it for the exact same reason. They say fee-for-service medicine forces providers, it forces doctors and hospitals to think about the volume of care that they're conducting business in as opposed to the value of that care. But there's two other problems about fee-for-service medicine that are never talked about. Far more serious than the volume-driven problem with fee-for-service medicine is that if you have a reimbursement system that pays doctors to do more, the device industry and the drug industry responds by developing new surgical procedures and new medicines that lend themselves to volume-based use. That innovation effect of fee-for-service medicine is enormous. We're seeing the innovation of new drugs and medical therapies that no other country in the world wants, but that will do extremely well financially in the United States. They lend themselves to being overused. And a classic example of that is something like the invention of cardiac CT, or CT in general, or moving from ceramic hips to titanium hips or something like that. Why do these things lend themselves to fee-for-service reimbursement? They lend themselves to fee-for-service medicine because there's an unlimited reservoir of 30-year-old men who are out of shape that we can stent. There's an unlimited reservoir of patients who need a hip replacement or a knee replacement. So in a fee-for-service reimbursement model, it can make a lot of sense if you are innovating these new technologies like cardiac CT and angioplasty and hip and knee replacement and mitral valve. In a fee-for-service system, you can really go to town with those kinds of technologies. If you had a value-based reimbursement system, we would not be inventing those technologies in the first place. And this is putting this innovation that fee-for-service creates, the innovation effect, puts doctors and providers under tremendous strain. Many of them know that the shiny new stuff that's being innovated is not really valuable. But if their patients want it, or if another doctor or another provider group is giving it, it becomes very hard for that provider to say, I'm not going to do it. They're going to lose money. And that's the diffusion problem. The diffusion problem is, even if that shiny new thing is valuable in some patients, you get to use it in everybody. This was a brochure pushing multi-slice computed tomography machine that Siemens Medical Solutions has developed. It's called a somatom machine. And I thought this was kind of interesting, so I opened the brochure. And I was really struck by this table inside the brochure. This is a table that tells me that if I, as a physician, bought a somatom machine and ran it 1.8 times a day, 20 days a month, Medicare would pay me $220 every time I would use that somatom machine. I'd have an income of about $8,000. So over 5 years, I would break even. Well, I don't want to break even. So I would run it 5 times a day, 20 days a month, get paid $220 by Medicare, and I would be, over 5 years, I would have made about $850,000. But why stop there? Because if I could run it 10 times a day, 20 days a month, get $220 from Medicare, I would make $2.1 million over 5 years. This is the problem with fee-for-service medicine, right? What is the problem? The first problem is, nowhere in this table does it say what was the value to the patient as a result of being put into a somatom machine. What would you see that you couldn't see with an MRI? Did you even need the MRI? Did you catch a cancer? How much longer did the patient live? That's the problem that Representative Ryan, Speaker Boehmer, and the President all agree on. That's the volume-based problem. That's that $220 problem. The bigger problem that I'm talking about is that fee-for-service medicine encouraged the development of this technology. We have to do in the United States what we did back in like 1908 when we created the Federal Reserve. In 1908, we realized as a country that the United States Congress was incompetent at setting interest rates. It couldn't do monetary policy. So we took Congress out of monetary policy, and we created a new institution. It's called the Federal Reserve System, right? So Ben Bernanke and all have complete control over the monetary system, and this is good because Congress cannot meddle in what Ben Bernanke does. And we have to do the exact same thing for healthcare. I don't think voters will ever update. So we have to remove the ability of today's legislature to raid education. So healthcare spending and what the healthcare programs look like and their growth and generosity should be decided by a deliberative commission full of moral philosophers and advocates and economists and physicians. But that group, just like the Federal Reserve, will be far more thoughtful and deliberative than voters will be. We've done this in Massachusetts. It's called the Healthcare Commission. The governor signed it into law in July. It had its first meeting 2 weeks ago. Massachusetts has realized this. And every other time that Massachusetts has realized something, the country has followed. So I remain extremely optimistic about this. So with that, I'm going to pause, and I'd love to get your questions. Thank you.
And one of the questions was exactly this issue of the generosity of the programs that we are accustomed to assuming that my insurance will cover this, and my insurance will cover that, and my insurance will cover the other thing. And no one has really raised the question as to whether we should cover all of those things. And that was one of the issues that came out of the conversation. So it's interesting to see the data that you're giving us.
And it's a difficult tension, right, Shani, because I wish at the end of the day they weren't economists. Like, I wish at the end of the day you could give everyone everything. But there is this trade-off that if we cover the frontline chemotherapy drug, that's less money to give someone else something else. But far more important, our ability to insure the uninsured permanently turns on our willingness to confront this tension between whom to cover versus what to cover. I think the president tried to create that institution. There is something in the Affordable Care Act called IPAB, the Independent Payment Advisory Board for Medicare. It's people who have a 6-year term. They're trying to get at something like the Federal Reserve. It doesn't have much power, though, is the thing. People said death panels. There were no death panels in the bill, but this thing was called the death panel. Ironically, the people who called this commission the death panel are essentially voting themselves higher taxes. I mean, it's like either the death panel or the 92% tax rate. But they're opposed to the tax rate, too. So it's sort of like, now what? My view is that there's a trade-off between living healthy, living wealthy, and being wise. You can have the healthy part by just having high tax rates, by having not the most generous programs. You won't be rating education. The UK has something like that, right? They have the NHS. It works quite well for them. But there's costs of the NHS. The NHS does not have the steady stream of innovation and kind of rapid fire assistance that we have in the United States. Which country works for you kind of depends on your preferences for that trade-off between living healthy, wealthy, and wise.
I look at the slide that showed in Massachusetts where the health increase, the health costs went up. You covered more people, but one of the things that was cut was mental health services. And then the question becomes about prevention and your individual who can't take his diabetic medicine. I just wonder if you could react or tell me what you know about the fact that sometimes mental health services help people stay in compliance with the meds to maintain their physical health. And how has that entered the conversation more than in my head and in the mental health provider world? Because I don't hear it being talked about on the physical health side very much.
I would say it has not entered the conversation. I'm a mental health clinician, and we have done a terrible job of advocating for what we bring to the table. It comes up a little bit, but in terms of being in the central part of the conversation, I would say we're not. We continue to be an afterthought, and when you talk to mental health providers and you ask them, do you go to policy meetings? Do you ever talk to your legislator? We don't tend to do the things that the AMA does, for example, that the pharma houses do. And so we have not been effective advocates to make sure that that voice is in the room to make these points.
And let me end with this collision between economics and equity. I want to draw your attention to a study that was done in Australia, where a very famous philosopher in Australia asked Australians, so the respondents here are Australians, and they might be kind of wacky. How would you allocate $1 million between 5 options? And let me explain to you what the 5 options are. Option 1, 2, 3, 4, 5. The options basically trade off how you spend the $1 million, and this table tells you how many patients' lives would be saved under the different options. So come over here. There are 50 patients in the 5th example. You spend all your $1 million on disease X. You save 50 patients with disease X, but you save 0 patients with disease Y. How many patients have you saved in total? 50. Now option 2. Option 2, You spend $1 million, you spend it in a way that you save the lives of 40 patients with disease X, 2 with disease Y. So in total, you've saved 42 lives. Come all the way over here. This is an allocation where you have saved the lives of 10 patients with disease X and 8 patients with disease Y for a total of 18 patients. So the bottom line tells you the number of lives that you have saved. And you're saving this total number of lives, which the bottom line gives you, using $1 million. So which is the most cost-effective option? This one. Because in each of these cases, you've saved 1 million lives, right? But in this one, you saved 50 lives. In this one, you spent $1 million, but you saved only 18 lives. You guys with me on that? You guys with me on seeing why the 50 lives for $1 million is the most cost-effective relative to 18 lives at $1 million, right? Now the question is, what did voters pick? Did voters pick that one all the way on the right? That's what economists would have picked, right? What did voters pick? Let's go to the next thing. Here's what voters did. Voters picked this middle option. 50% of voters picked this option where only 34 lives would be saved. This is the most cost-effective option, and that was only picked by 6% of voters. Voters picked this least cost-effective option 5% of the time, right? Ultimately, we live in a world where voters make decisions, not economists, not doctors, not providers, right? And if voters are not willing to kind of take on cost-effectiveness analysis, voters have an embedded sense of equity. They have a notion that I should spend money on people even if it's going to generate no value, right? So that's a tension that we have in my world of economics, because ultimately we don't think that economists can tell people what their sense of social justice ought to be. Our world is very much a world where we take people's sense of social justice as given, but if you take it as given, you will pick this option. You will save the lives of 34 people when you could have saved the lives of 50 people. You chose to basically let 16 people die because of a sense of equity. Now, you could say, this is all Australian voters, and American voters would never do this, but I would quibble with you on that. So let me end with that tension between economics and equity. And I'm not saying that this is the wrong answer. I'm just saying if you let voters engage their preference for equity, it is an expensive preference. It is not for free. Thank you. Thank you for inviting me out to this event today. An economist like me is good at measuring the costs of different options and informing people about the trade-offs that society confronts. But ultimately, at the end of the day, someone has to do the work. And that's why it's really exciting to work with an organization like Culture Insight, because you're out there on the front line helping people get better, changing the culture of healthcare. So thank you for this opportunity.